this up now to the entire group for comments either specifically related to the presentations, the 4 excellent summaries that you just heard, or other specific comments that you have to make. Please introduce yourself first and make sure you go to one of the microphones.
Bob Yolkin, I have a question for Dr. Griffin. Did you discuss the issue of the containment level for the virus? Because our experience, if you try to develop animal models, trying to do on a BSL-3 is much more difficult and slowed down to BSL-2, yet there may be some issues in that. I wonder if that came up at all.
This is a BSL-2 agent, so that issue is not the huge one. But and there was some data that was talked about at in our session on semen studies in mice, showing that that other flaviviruses can infect. But so those kinds of studies can be done, and I'm sure are being done.
Hi, I'm Diana Weber. I have shipped samples across international lines under CITES many times and recently published a paper on CITES. So I'd like to address the last breakout group. For endangered species and species that are under CITES, you're not going to be able to circumvent CITES or other international laws, especially US laws. So maybe the plan would be to expedite approval between countries, because the CITES it has to do with approval between the exporting and the importing countries. But you're not going to be able to circumvent it to import samples.
I mean, in defense of breakout group number 4, I don't think anybody was talking about circumvention. I think they were talking about facilitation and perhaps pre-positioning of such agreements, because it takes long enough to do them that it's very hard to do them in the course of a crisis. And everybody's so busy with the crisis that they can't really do it right then.
Right, and I can appreciate that, and maybe you look at expediting the permit process.
Dan Strickman from the Bill and Melinda Gates Foundation. You know, listening to all the breakouts together and our own one on vectors, maybe this is the wrong group, but maybe it's the right group to contemplate a set of best practices for response, because all these different things, they're bullets there that are, some of them are quite immediate and very important. But to assemble those into a set of best practices for an entity, for the U.S. federal government, for foreign governments, et cetera, might be just a very small but next step.
It's worth pointing out that some of the bullets were on our slides from the Ebola Rapid Response Workshop, too.
Exactly. I think that's an excellent idea, to try to approach this as generically what's the best response, and then pre-position those things. Be prepared.
Mehrshad, Harris County Public Health, and again, thank you. Excellent job summarizing. I somehow got into 3 of the 4 groups, so I think you guys did a fantastic job, what I heard. I wanted to add two points. One was around the real understanding about animal vectors, I should say animal reservoirs, and the potential for animal reservoirs as being a source of transmission based on what we know or don't know, and companion animals and other animals that really come to mind. And does that change when we have potential for saliva and bites and things? You know, you can start going down a list, but are there some unknowns there that we really need to be aware of? The second point is really it's more of a applied research piece, which is the real challenge in many mosquito control programs around the country, is that there are very QLEX, West Nile virus centric programs. They're focused in that way, a completely different strategy. And now you have additional strategy now coming from daytime biters and the potential with Zika virus. And so really the question is about, are there opportunities of looking at research on how, again, with the point that was just made about best practices, about layering or surging on top of that baseline rather than having two separate siloed programs that are operating independently, but how can you have complementary programs? And I don't have a good answer to that, but it would be great to be able to get some thoughts and research into that. Thank you.
Thank you, Dr. Shaw. I think our group would 100% agree with you related to the animal reservoirs. That's part of that first bullet that we have, that we need to understand the biology, the different vectors, what mosquitoes can carry it, but also the reservoirs, and also understand that here in the United States, but also in Central America. And so are they different? Are there animals here that could potentially play into that viral replication? But that was our thoughts related to that first bullet point.
You know, a point made in our group was the need to coordinate data from human epidemiology with vector epidemiology, as well as to coordinate the control efforts, you know, as was attempted in ARPANET, but it needs to be retooled for this.
The one area that I haven't heard is the concept of One Health, the zoonosis, entomology, human health piece, and that may be a way to help frame it. Thank you.
Peter Police in Mount Sinai, New York. Dr. Victor Zhao was mentioning in the morning that he was proposing an R&D program of $1 billion annually. Can we get some more sort of traction on that idea, and who should really, I mean, from where should that money come? And I just think it might be interesting to hear either from the panel or from Dr. Zhao.
It seems to me that that recommendation for $1 billion wasn't just for Zika. It was for a much broader level of preparedness, and that, you know, when you look at, at the end of our session, one of the people at the table said, you know, now here's the important question: how do we know which one is next? And we don't. And I think that this Zika situation really highlights the importance of the recommendation in the Global Health Security Report, and the fact that there's so many potential threats and we have no way of knowing what's the next one, and that we aren't doing the research to prepare for them.
Victor.
First, thank you for raising that issue. Please read the report. But I think I can tell you that the way the number was compiled is based on several different sources that it wanted to leverage and partner together and go forward. Public-private partnership, investment from pharmaceutical, biotech companies, academia to government. And I don't know if Peter Hale's here, but in fact, Peter, you may want to...
Peter Hale is here.
So there's a number of initiatives going on right now, including Peter and Jeremy Ruskin, Jeremy Farrar and Adele Mahmoud talked about the vaccine development fund. In addition, our report talks about an initiative to bring together independent committee to bring together local ideas of public-private partnership. The World Economic Forum has initiated a group with the Secretary to start bringing, again, public-private partnership. Many of you know some of the companies are putting their platform available to work together to move vaccine faster. So there are real initiatives, just not numbers. But Peter, you may want to say a word on what you find out.
Hi, Peter Hale with the Foundation for Vaccine Research. We published a paper in the New England Journal of Medicine last July calling for a $2 billion global vaccine development fund to speed the development of candidate vaccines that can't raise the money to get from preclinical studies into human clinical trials, the so-called value of death. We know that when the Ebola epidemic burst in West Africa, we had 7 very promising candidate vaccines for Ebola. All of them were stuck because they couldn't raise the money to go forward into human clinical trials, all with the exception of one. And we know how much that cost us. And we're going to go through the same situation again and again. Right now we have NIH has a chikungunya vaccine, a VRC, a MERS vaccine, and a West Nile vaccine. They're not getting much industry from the 4 major vaccine manufacturers to take them forward, so they're stuck, and so they go back into the freezer. So there is a need for a new financial mechanism to mobilize the assets needed to put these vaccine candidates into advanced development.
To follow up on this issue of the regulatory environment and how it impacts research and response to things like Zika, I think it's a very significant major problem in research on all kinds of viruses, emerging viruses, and responses. I'd like to just give a couple of examples of how absurd the regulations can be. We learned, our campus is home to the World Reference Center for Emerging Viruses and Arboviruses. It's a collection of about 6,000 different viruses supported for many decades by the NIH and the DoD at one time. We learned last year that most of our virus strains are pathogen virocells, African green monkey kidney cells. We learned last year that we need a CITES permit to send any virus strain out of the country that was pathogen virocells. And we confirmed this with the attorney here in Washington who interprets these regulations. It took us 4 months to get a CITES permit in place. We were virtually shut down shipping viruses out of the country during that time. How using virocells that were generated decades ago as a continuous cell line impacts the welfare of African green monkeys today, I have no answer for that. Second example, Department of Commerce export permits. Zika, fortunately, is not regulated by the DOC, but chikungunya and dengue are. So every time we send one of those viruses out of the U.S., we have to get a DOC permit, even to send them to their country of origin in some cases where they were sampled years ago. That usually takes us 2 to 3 months waiting for one of those permits. Plus, on top of that, our own university regulatory system, we have to get MTAs for shipping almost any kind of biological sample anywhere off of our campus. That often takes a couple of months to negotiate the wording in the MTA that's acceptable to both parties. This really inhibits the flow of reagents, virus strains, and the progress of research. And I think this is an area that the National Academy might be able to address effectively, at least with the U.S. government. Thank you.
Does anyone here want to make more comments on that topic?
I can't comment. I mean, I don't want to comment on the issues around select agents and animals, but were this an outbreak in which we had the ability to do human studies rapidly, we would run up against those issues that we've talked about here and elsewhere for many years with the ability to do rapid research in an emergency in people. And those problems haven't been solved yet, whether it's the use of a single IRB, the rapid contracting, the fast flow of funds. I mean, there's been progress. This would be a good test. The bad news is we have no vaccine or drug to deploy in this outbreak at the moment, so we're not faced with those problems.
And if I could add, again, I think those are very important points, and it helps to put some specificity to some of the issues that we were discussing in our group. And it's not a matter of needing to dispense with something like an MTA, because obviously you don't want misunderstandings about what, who owns what material, where it came from, what its origin was, but that it has, all of these issues have become far too entangled in complex legalisms that aren't necessary in order to achieve those goals. And so I do think it's a good area actually for the national academies to look at, because it does seem to me one could standardize on some of these things. I mean, I personally have spent more time than I want to remember, going back and forth about silly language and MTAs that it's not the best use of anybody's time, even if it's not an emergency. And if it's an emergency, then it's you're basically not saving lives when you could be.
We wanted to have time also to allow any participants, including those who are sitting up here, to bring up issues that were not included in the four sessions that we discussed. Are there things that were not on the radar screen that in fact should be mentioned today?
George Sadi, University of Texas Medical Branch. This morning at the plenary session, I saw a map of the areas affected, and there were quite a lot of countries where it said, the map said serologic evidence. For example, I saw India, Vietnam there among many others. So my question is, why are we focusing only on the few countries that we know there was microcephaly, and are we doing anything with in these other countries? How does that affect causality also?
I don't have an answer to your question, but I've wondered the same thing myself, or to put in another way, this is a virus that's been prevalent in many parts of the world and that it's infected many, many people, and why haven't we detected microcephaly before today, before last year? And it does seem like something that could potentially be evaluated, although I think if there isn't current infection, then it would be very challenging to retrospectively determine if somebody had had that particular infection, given the non-specificity of the symptoms and the fact that it resembles so many other febrile illnesses. So even among those who are symptomatic, I think that, without having the ability to nail it serologically, it's going to be very hard to go back and say, well, if there was some, if there were microcephaly cases, say in the 70s, in Africa, that it was or was not caused by Zika. I also thought what somebody said earlier today was interesting, that, perhaps there's some immunity conferred by having childhood infections, as we used to see with rubella, so that we didn't have the numbers of cases of congenital rubella that one might have expected, because people had childhood infections and had some immunity from that. And so it may be a different dynamic in a place where it's been endemic than in a place where it's spreading to and it's epidemic, and adults are getting infected for the first time in their lives. That's another possibility.
I just comment that I think this is like lots of emerging infectious diseases that have been around for a long time, and we don't recognize them or recognize how serious they are or what the complications are until a situation like this occurs. And then prospectively you study it, but then you can also retrospectively be looking for it elsewhere. So there's numerous examples of diseases and complications that have been going on for a long time that we just didn't recognize. There weren't enough of them that were happening.
And the other issue that has also been mentioned is whether there has been a change in the virus. And I think all of these are areas that deserve further study.
Sorry, I just didn't make myself very clear, but I realize all of these are reasons why we see microcephaly here but not there, but why aren't we also studying it in these other countries where we don't see the microcephaly?
I'm not sure that we're not seeing it. Also, it has to be looked for.
I think it probably also points out the difficulty of looking for congenital anomalies and doing birth defects research in areas with high levels of poverty, high levels of environmental contamination, high levels of congenital infection. I doubt birth defects research rises to the top of the agenda.
And you didn't say it, but also higher rates of infant mortality.
Yeah, of course.
And so often birth defects are on a spectrum that also involves infant mortality and fetal loss, spontaneous abortion. And so, where an outcome is on the spectrum can involve, the multitude of factors that impact on the fetus. But I do think there's probably people who have done studies in those countries that have banked serum and maybe even cord blood, and there might be the opportunity to go back and look at some of those. I just have a feeling that there are such resources available.